Good evening. Welcome to the ACR Town Hall on the COVID vaccination, immunosuppression, and rheumatic disease. I am Marcus Snow, the chair of the Committee on Rheumatic Care with the ACR. I'm a practicing rheumatologist in Omaha, Nebraska with Nebraska Medicine and with the University of Nebraska Medical Center. I will be moderating this hour-long webinar tonight with Dr. Huston, a private practice rheumatologist in Kansas City, Missouri with Kansas City Physician Partners. Quaz currently serves on the board of directors with the ACR. We have a great group of panelists tonight scattered throughout the country who will be speaking on the current understanding of COVID vaccination, immunosuppression, and rheumatic disease. We will start with 3 short talks and finish the hour with an extended question and answer. Before we start, a few ground rules. At the time of the registration for this town hall, you have the ability to submit questions regarding vaccination, immunosuppression, and rheumatic disease. Many of those questions will be addressed during this presentation. You are also encouraged to submit questions throughout tonight's presentation using the question and answer box. We will answer as many of these questions as we are able to do so in the hour-long presentation. However, we will not be taking any verbal questions, and we will not be following the chat box during these presentations. You should know that this presentation is being recorded. The panelists here are here by invitation from the ACR, but their opinions are their own, and they do not necessarily represent those of the ACR. Our panelists tonight include Dr. Al Kim from Washington University in St. Louis, Dr. Jean Liew from Boston University, and Dr. Michael Anderson from Health and Human Services. Our first speaker tonight is Dr. Kim. He's an adult rheumatologist and assistant professor of medicine at Washington University School of Medicine in St. Louis, Missouri, where he co-directs the Washington University Lupus Clinic. His colleagues, along with colleagues from UCSF, have been examining the impact of immunosuppression on immune responses and adverse events of rheumatic disease patients following SARS-CoV-2 vaccination. Dr. Kim will speak on the latest on the effect of immunosuppression on vaccination. With that, I will turn it over to Dr. Kim.
All right, thank you so much, Marcus. I want to thank the American College of Rheumatology for giving us the opportunity to discuss this very high level, relatively brief 10-minute discussion about what we do know about the immune responses following SARS-CoV-2 vaccination in the context of immunosuppression in rheumatic disease patients. So I have no relevant disclosures. Next slide. So what we're going to be reviewing today initially is going to be how do vaccines work. We're going to describe at a high level the players, both in the immune system that enables for vaccine responses to be mounted. But also I want to help normalize the ground by making sure that everyone understands the terminologies that are being used to be able to describe these vaccine responses, in particular to antibody responses. Then we'll review some of the data demonstrating the impact of various immunosuppressive medications on antibody responses following vaccination. And then we'll wrap up by describing what we still do not understand, which is a substantial amount. And this is leading to probably many questions that many of the providers are getting within the clinic. Next slide, please. So how do vaccines work? Everyone really talks about antibodies, and this is going to be in the upper middle part of the cartoon here. But at some point, you have to activate numerous other aspects of the immune response to get to these antibodies. So if you look at the far left and delivery of the vaccine here, in this case, it either could be the mRNA vaccine, the Moderna or Pfizer, or it could be an adenovirus such as J&J. What ends up happening is that eventually what the immune system picks it up through these antigen cells, which then activate these T cells, in this case, something called a helper T cell. These helper T cells are absolutely critical in mounting future responses. You can see in the top, these helper T cells actually help activate a cell called a B cell. These B cells have to be activated in order for them to basically develop and differentiate into cells that will allow for antibody production. So at the very big top line, again, you need these antigen-presenting cells interacting with helper T cells. These helper T cells then help the B cells move into the direction where they can make antibodies, and this is what everyone talks about. I just want to highlight, though, that there is this important bottom line, too, that these helper T cells also help mount additional T cells. These are called killer T cells, or in the immunologic world, cytotoxic T cells, which can actually help kill virus-infected cells. And so through the actions of both, you can mount immunity against virus infections. Now, one of the other outcomes here that's important is going to be the generation of memory cells, either memory B cells, memory helper T cells, or memory killer T cells. And these are things that help allow us to maintain a durability post-vaccination that can last for years. Next slide, please. So I want to define some key terms here. And what we're going to be talking about in this particular talk is going to be immunogenicity. And so what this means is it's going to be the assessment of the components of the immune response following vaccination. This does not mean protection per se. These components help add into this idea of protection. But what we're doing is we're breaking down the immune response into its kind of core elements and then measuring those individual elements. So one of the elements we can measure is going to be antibody titers or levels, either one. This is essentially measuring the level or the amount of antibodies that bind to something called the spike protein. SARS-CoV-2 virus itself has several different genes in it, but the part that is in the vaccines is going to be this little tip here in the green called the spike protein. And this is actually blown up here in a kind of a cartoon of the structure of the spike protein here on the right. So if you have anti-S or S antibodies, and you're just measuring antibodies against that in an assay, you're basically saying that you have antibodies that bind to any part of this spike protein here on the right. And so, again, there's a couple ways that this is relayed out in terms of data. We can measure levels or titers, but the other way people have been reporting it is through something called seropositivity. And this is where you're just saying, did they have a positive or negative test? You're actually not really thinking about levels at this point. They're just asking whether or not you're having a response at all. But there's actually a specific type of antibody that can then lead to another type of assay that can be done called neutralization titers or levels. So the part of SARS-CoV-2 spike protein that's really critical for establishing infection is actually here in the green. It's called the receptor binding domain. And so antibodies that actually can bind to that RBD can actually induce what's called a neutralization response. This is actually something we measure in the lab in a Petri dish, something called what we say in vitro, where essentially you can take a patient's a vaccinated patient's sera and then add it into a culture of cells and then add virus to that. The cells usually will die when infected by the virus, and they can leave these little plaques or little holes in the lawn of cells. But the more neutralizing antibodies you have, the fewer number of these holes or plaques that you have. So the lower the number of these plaques, the higher the neutralization you have within your antibodies. And so this is what we call neutralization titers or levels. Next slide, please. So I want to highlight several efforts that have been paramount in being able to generate the next several slides that give us at least an initial glimpse of the immunogenicity associated with the immunosuppressed. So the two biggest efforts globally has been Julie Pak's effort at Johns Hopkins University with Dori Segev. They have the largest US publication with over 400 subjects. Victoria Fura at Tel Aviv, Israel has another paper with over 600 subjects. I also want to mention Bimba Hoyer's effort at Kiel, Germany, where they were the first to describe this in a small cohort. There has been also efforts by the Saga cohort led by Jose Schur, along with the help of Mark Mulligan, and also their collaboration with Jörg Schett and Erlangen. And then our efforts, the Coverapath study, which is a joint Washington University and UCSF effort. I do want to acknowledge just a handful of people: Parakal Deepak, Woo-Sup Kim, Michael Paley, Rita Chen, Ali Elabedi, Mike Diamond, Willie Busher, and Sean Whelan. This is a massive effort with over 70 people on these teams. And then also at UCSF, Mary Nakamura, Leanne Gensler, Merdad Merivian, and Monica Yang. And again, the work that we have put into this, I really appreciate the efforts of the other cohorts because it's been a very challenging study to be able to implement. Now, based off all these efforts, and I put all the references of the relevant studies I find that are important for understanding at least our initial glimpse of antibody responses in the immunosuppressed here in the bottom right, is that number one, most people who are immunosuppressed, regardless of medication, for rheumatic disease will will become seropositive. And the numbers within these studies list anywhere between 75% to 94% of rheumatic disease patients on immunosuppression will become seropositive. This is compared to about 95 to 100% in both the clinical trials, but also in the immunocompetent participants within these studies. Now, if you look at the actual levels in general, there is a modest decrease in the levels compared to the immunocompetent group. And so this is anywhere between a 1.4-fold to 3-fold less reduction in antibody levels. Does this mean you're less protected? This is an answer I can't provide, and I don't think we're going to have an answer for this anytime soon. But what is encouraging, though, is that for most of these people, neutralization titers seem to correlate well with antibody titers. In other words, if you're able to make these antibodies, a certain proportion of those antibodies will neutralize. And we know that these neutralizing antibodies appear to be an important correlate of protection in people. So this is something that's very important. So I think, again, this highlights that the vaccination of the immunosuppressed with those with rheumatic diseases is effective for the most part. Of course, there are going to be certain medications that will drive greater decreases than others. And this is going to be on the next slide here. So the first one, and this is not going to be a surprise, are going to be these B-cell depleting agents. This has been well established for hepatitis B and influenza. And in the studies that are listed at the bottom here, we have seropositivity rates anywhere between 26% to 68%, and then decreases in titers anywhere between a 7-fold reduction to over a 625-fold reduction in the Johns Hopkins cohort. The main issue here, though, is probably going to be the timing of the vaccination after the last dose of the B-cell depleting agent. This is data from just 10 patients in our COVARIPAD study, but you can start seeing is that around month 6, we start to see a separation of some of the people who are on, in this case, rituximab, and starting to generate titers as long as they're about 6 months or after from their between their last dose of rituximab and the time that they got vaccinated. There are additional data, though. Next slide, please. Especially from Thomas Dorner's group, which is shown here, is that the presence of peripheral blood B cells appear to be a key measure or a key surrogate of whether or not you will generate antibody response after B-cell depleting therapies. And this again makes sense because I told you earlier that B cells are important for mounting antibody responses. And I'm sorry about the formatting of this slide, but essentially what they measured out in their study is about 10 B cells per microliter of blood is going to be a threshold where they start seeing antibody responses. And again, there are other studies. There's another Israeli study from Haifa that in those who've been immunized, vaccinated within 6 months of their last rituximab dose, only 20% of those people seroconverted, but a year later, it ended up being closer to 50%. I wanted to highlight that particular study because it is one of the largest studies in terms of B-cell depletion. Next slide, please. But B-cell depletion is not the only type of therapy that attenuates antibody responses in a profound way. Mycophenolate, also probably not surprisingly, also caused substantial drops in seropositive rates and antibody titers. In the studies listed here in the bottom left, it's anywhere between a 64 to 73% seropositivity rate. And in terms of studies that actually measure titers, at Johns Hopkins, they saw a 31-fold reduction in antibody levels. And this is shown here on the right. You can see overall of the rheumatic disease patients on the far left here. You can see mycophenolate in the second column here, and you can also see rituximab people both having very poor responses. Next slide, please. So the responses with prednisone are a little bit more varied, and this is probably a little bit surprising. One could say that this is mostly due to the dose of prednisone, which would make sense because the higher the doses, largely you have increasing immunosuppression. And certainly within the studies of those on prednisone, you can see rates between 64 to 82% seropositivity rates and titers that drop anywhere between 10 to 31-fold. One of the things that we found in our particular study at COVARIPAD was that even people with low dose prednisone use still were, a fraction of these people were unable to mount antibody responses, which is quite surprising. But I think the data from Julie Pak's effort at Johns Hopkins shines a little more insight in this. Next slide, please. And again, you've seen this data before. If you look in the far right, to the two right columns here, you can see that those people with combination therapy with glucocorticoids versus those that are taking glucocorticoids by itself, it seems that their combination therapy is another major player here, potentially in addition to dose, that attenuates responses. Interestingly enough, in glucocorticoid monotherapy in their cohort, they were able to generate very good responses. So I think this highlights, again, this very complicated interaction of having multiple immunosuppressives on board, which is going to then complicate, answering questions for specific patients that are likely going to be on more than one immunosuppressive medication. Next slide, please. So methotrexate, I'm going to wrap up with this. Responses with methotrexate are also a bit varied. We see seropositive rates all over the place, between 47 to 87%. I think in general, though, with the data that we know with influenza, we do know that methotrexate can attenuate responses. And again, we're seeing more modest reduction in titers reduction. So here in the Erlangen cohort by Jörg Schett, it's going to be 1.5 all the way to a 3.25-fold reduction in our study, and also a large psoriasis study from a London cohort. And so again, the references for those are going to be here in the bottom left. So at the end of the day, next slide, please. It seems like that there are certain medications that definitely attenuate responses. We're definitely talking about B-cell depleting therapies, mycophenolate, glucocorticoids to a certain extent, although we don't fully understand how the effect of combination therapy or dosing, I don't think quite yet. And then the other ones are a little bit more modest: JAK inhibitors, antimetabolites like methotrexate and leflutamide, and then TNF inhibitors, another major group. Again, we only saw a modest reduction in our cohort, about 2.5-fold decrease in titers. Next slide, please. So what do we not know? This is a lot. So I mentioned before that right now what we can do is I can tell you what your levels of antibodies are. But the problem is that what level of antibody actually is required to mediate protection. And I can't answer that right now. And so the effectiveness of vaccination in these type of studies will eventually help answer this question, but this is going to take quite a bit of time. Another question that I'm sure everyone's getting is, what about this Delta variant? Or even people who are vaccinated appear to be able to transmit some virus throughout to others around them. And so the other one thing we're not 100% sure yet is, are these breakthrough infections more likely in the immunosuppressed? I think what we will find out in the future is that those with poor or absent antibody responses, for example, will be more likely to have these breakthrough infections, because obviously the vaccination did not work as optimally as we wanted to. And then, of course, in terms of vaccination and Delta variant, what about protection from severe COVID-19? Again, I think there's some really good data in the competent group that vaccination is highly effective against hospitalization and ICU stays. But whether or not this is also observed in the immunosuppressed with decreasing titers of antibodies, this remains to be seen. Next slide, please. There are 3 questions here I'm going to just fire off back to back to back, because there's no answers to this quite yet. First of all is durability responses. I would actually make an argument that the responses that we're all measuring, which is pretty much right after the second dose of the mRNA vaccine or within a week or 2 after the J&J vaccine, might be a little too early to measure vaccine responses. And the reason why is that while the peak antibody responses can be observed at that early time point, there's some very nice data from Ali El-Abedi that shows that germinal center responses, so that's going to be that T-cell, B-cell interaction I showed in that top row in the early slides, those reactions can last for 3 to 4 months post-vaccination. The reason why I'm bringing this up specifically is that a great deal of antibody diversity is generated through these germinal center reactions. And so we all focus on levels of antibodies, but the other thing I think we haven't really paid attention to is the diversity of antibodies. And the reason why diversity is important is that this has the ability to then neutralize emerging variants. And so this is something that needs to be examined by all of our groups in the near future. The role of boosting, I think we're going to get a lot of questions on this. I think in general, everything is pointing to the idea of boosting the immunosuppressed, particularly those with poor or absent responses. But again, right now it's difficult to get because of the EUA designation on our vaccines. And then the other thing too is these drug holidays. Current ACR guidelines probably appropriately ask people to hold certain type of medications in order to optimize the responses. But I think what's not clear is the timing. How long do you have to hold before and after vaccination in order to generate these optimal responses? I'm just going to briefly leave a few of these references here on the bottom, because now they're starting to become some nice data about T cell responses. And again, remember I showed you kind of that bottom row of T cell responses. And of course, these other studies are also looking at memory T and B cell responses too. So these studies are going to be coming out. Whether or not they're sufficient to mount protection also remains unclear. So you've probably heard me say unclear a fair number of times. I think if this talk is going to be given in December or January, the talk would be quite a bit more sophisticated, but we'll still have numerous questions. So in general, people are being largely generating immune responses to vaccination. I think that's absolutely critical. And there's some trouble spots though in terms of B cell depletion, mycophenolate, and likely prednisone. Thanks.
Thank you, Al, for that great overview in a very brief amount of time. For all the attendees, we will have a question and answer session at the end where you can put questions in the question and answer box. And Dr. Kim, Dr. Liew, and Dr. Anderson will be answering questions at that time. So we were going to move on. Dr. Liew is an adult rheumatologist and assistant professor at Boston University School of Medicine and a member of the COVID-19 Global Rheumatology Alliance Steering Committee. She will speak on the mindset of patients regarding vaccination, medication use, and their experience with vaccination. Dr. Liew.
Thank you for the ACR for inviting me to give this talk, and thank you to the GRA for allowing me to present some of our unpublished data so far. Next slide. So I'm going to hopefully complement Al Kim's talk with talking about more of the clinical approach. I'll be briefly talking about some barriers to vaccination, medication changes around the time of vaccination and patient concerns about that, as well as some studies showing side effects from the vaccine and the risk of rheumatic disease flares after receiving the vaccine. Next, please. So to talk about barriers to vaccination, so as a representative study, we have this study from France of RA and spondyloarthritis patients before COVID-19. So this looked at pneumococcal pneumonia and influenza vaccinations. And they found that the main reason for not getting a vaccination was a lack of physician recommendation. So this could be either their rheumatologist didn't talk about the vaccine at all, which is probably more common, more frequent, or they recommended against getting it. And in these blue boxes at the bottom, there are several other studies that found a similar barrier. And again, this is pre-COVID, but we think this is probably still in play now. So next slide. So patient concerns are probably in two buckets, a lot of which Alan's talked about in his talk, but related to either the efficacy of the vaccine, will this vaccine work for me, and the safety of the vaccine, will the side effects be worth the risk? So patients might ask, will this vaccine protect me given my underlying disease and the medications I take? And if it doesn't protect me as well, are the risks worth it? And regarding safety, am I going to have severe side effects versus somebody else who doesn't have my underlying rheumatic disease, or are the medications I'm on going to make the side effects worse? Is it going to cause my disease to flare? Next slide, please. So earlier in the pandemic, we had several studies that showed that people were making medication changes, stopping them or holding them without having discussion with their rheumatologist. And this is a representative study, again, of 1,500 respondents from the Arthritis Power Creaky Joints Survey. And 15% of people who were on a DMARD at the time had stopped it. Sorry. And the majority of these did so without physician recommendations. So this was early in the pandemic. There was a lack of data about what to do specifically, and maybe people didn't have as good contact with their rheumatologist. So things changed now. So we have had 3 iterations of the ACR COVID-19 task force recommendations on vaccination, and they specify what to do with your medications, timing, dosing, should you stop it or hold it. And the 3rd iteration has just come out with a complete manuscript recently. So maybe things are better now. We have more guidance. Next slide. So the Global Rheumatology Alliance, or the GRA, which is a group of patients, clinicians, and researchers, we have developed this survey online that was launched in April of this year, intended for people with rheumatic disease, and we're interested in responses from people who have either been vaccinated at the time of the survey or not yet vaccinated. And we wanted to look at concerns, attitudes regarding vaccination in general, and specifically related to the COVID-19 vaccine, as well as medication changes around the timing of vaccine, and then if they've been vaccinated, whether they had side effects in flares of their underlying disease after receiving the COVID-19 vaccine. And what I'm presenting here is the unpublished data. So this is going to be new for everyone, I hope. Next slide. So in the first month that the survey was online, we took all our respondents who had reported receiving at least one dose of a COVID-19 vaccine. So everyone who'd been vaccinated, this was about 3,000 people. And in this table, you see their demographics. Overall, they were older, given the vaccine rollout at the time, and the majority were female, white, and from North America or Europe. Next slide. And then this table shows that RA was the most common disease that they reported having, and you see the rest of the breakdown here. In terms of the percentages, this was because we had patient organizations that were disseminating the survey, so if you see something that's overrepresented, that is the explanation for why. Next slide. And then finally, in this table, you have the medications that they reported taking at the time of the survey, and about a quarter were on steroids of some dose. And then for this list of DMARDs, we tried to highlight specifically the ones that the ACR guidelines had recommendations for holding around the time of the vaccine. So that would be methotrexate, MMF, abatacept, rituximab, JAK inhibitors. Next slide. So this is the big graphic that I want to show. So most participants, 67%, agreed with the question about temporarily discontinuing your medication if that would help with vaccine effectiveness. And then when asked about the specific medications that they were taking, the majority again said they were willing to discontinue these medications if it would help with the vaccine being effective. So this figure breaks it down into medication class, and again, we've pulled out methotrexate, MMF, rituximab, JAK inhibitors. So with methotrexate, which is the top row, you see in blue that the majority, again, are willing to discontinue or hold the medication during the time of vaccine. And that's also true for the other medications that the ACR task force has recommended holding if disease is stable at the time of the COVID vaccine. The other interesting one is steroids, which is the second row. So the red bar indicates that they said, no, they're not willing to discontinue the medication for the vaccine. And that's not surprising because one, so people that are on steroids probably have more severe, more active disease, so they would be less likely to want to discontinue their medication. And then we also advise patients to not abruptly stop their steroids because that could have other negative effects for them. Next slide. So then when considering vaccine side effects, people with rheumatic disease would like to know if these side effects are going to be different for them versus the general population. So we have the CDC data from the people in the trials, and then from their VSafe registry of what kind of side effects were common for each type of vaccine. For rheumatic disease population, we now have multiple studies reporting side effects and what percentages those are. And I've just chosen a couple to show here. The first one is a physician registry from Europe, the EULAR-COVAX registry. So this is all physician reported, and they have 31% with potential vaccine-related side effects out of about 1,500 patients. And then in the GRA survey, which is patient reported, we had nearly half who had at least one side effect that lasted at least 2 days. But you see that the breakdown is these are all common side effects that we know are associated with COVID vaccines. Next slide. So then what about rheumatic disease flare after getting the vaccination? So again, in the COVAX physician-reported registry, you had 5% that had a flare, and then 1.2% were reported as severe flares. And if you read the EULAR abstract where this was presented as a late-breaking abstract, they describe what the severe flares were. In the GRA survey, we had 13% with a flare lasting at least 2 days, and then about 5% with a flare that required a medication dosage change, so like more prednisone, a higher dose of prednisone perhaps. And then in the VACO-LOOP survey, which is based in France, with people with lupus, 3% reported a flare. And in these smaller prospective cohorts, disease activity remains stable after COVID-19 vaccination. And this is not a comprehensive summary of all of the papers so far that have reported rheumatic disease flares, so we can talk more about some of them, but they're all pretty similar to this. Next slide. So in conclusion, from my part, we know that there are many patients that are still hesitant or deliberating about vaccination, so we need to have continued communication about that. And then when they're ready, to have shared decision-making with them about whether it's appropriate for them to hold their medications around the COVID vaccine in order to boost efficacy. Again, the ACR guidelines do not say that you should do it for all cases. It's still an individual case-by-case basis. And then finally, we need to continue having discussions about vaccine safety and efficacy for this specific population using the available data that we have. And as you see, every day we have new data coming in, and it's really hard to keep abreast of the situation. So I think we're all trying our best, and since you're here tonight, I think we're all trying to figure out what's the best way to keep moving forward. And as Al alluded to, we still don't have the answers to the last bit, but we will be welcome to discuss this in our Q&A. And then if anyone has questions about prior GRA work, about medications and COVID risk and things like that, if we have time, we can talk about that too. And that ends my part. Thank you.
Thank you, Dr. Liew, for that great talk. We will be moving on to Dr. Anderson. Dr. Michael Anderson is a pediatric critical care physician, healthcare executive, child advocate, and nationally renowned expert in disaster response and health policy. During the COVID-19 pandemic, Dr. Anderson was asked to join HHS full-time and is currently a senior advisor to the Assistant Secretary of Preparedness and Response at HHS in Washington, D.C. He is currently a key leader on the COVID-19 monoclonal antibody therapeutics team. He will be speaking to therapeutics available for those who have contracted COVID and on how these medications can be accessed urgently. Dr. Anderson.
Thank you so much. Can you hear me okay? I'll presume yes. Next slide, please. It's really an honor to be with the ACR, and this is a complete sidebar, but I was involved early on with the MISC, trying to figure out what it was and how we could treat it, and ACR really stood up and helped and continues to do that. So we're not here obviously to talk about multisystem inflammatory syndrome in children. Suffice it to say, as a pediatrician, I'm still concerned that we're going to start to see numbers increasing as we go into the winter, but a different topic for a different day. As Dr. Snow alluded to, I'm part of the COVID response, or the federal COVID response, and this is really an interesting schematic of patient progression from left to right with COVID-19. On the far left, I really appreciate my two previous colleagues talking about vaccine and how rheumatologic patients may have a different response. To the far right is those unfortunate patients that are admitted to hospital or admitted to ICU. Suffice it to say that the mortality rate still remains unfortunately very high. So we as a nation, and that is academia with ACR and the great work that you do every day, it is with the pharmaceutical industry, and it's with us in the federal government. We have to continue to push forward to improve the outcome of these patients. When we talk about the 3 EUA-approved monoclonal antibodies, we're really talking right now about this early sort of darker blue. That's the early symptomatic patient. These are patients that unfortunately have turned positive for COVID-19. Either they didn't get the vaccine, and I'm actually on deployment right now with HHS in areas where we see complete vaccine hesitancy or large amounts of vaccine hesitancy, or the vaccine hasn't taken. And I think, once again, my two colleagues did a wonderful job of delving deeper into the science of that. So these patients are early, they are symptomatic, they're within the first 10 days of their symptoms, but they're not sick enough to be admitted. So they're not markedly dyspneic, their O2 requirement either is non-existent or they haven't gone up. And we have a very important window with these 3 EUA-approved monoclonal antibodies. Once again, you can see one by the Lilly Corporation, one by Regeneron, and a brand new one from GlaxoSmithKline. These, in study after study, have proven about a 70% decrease in the need for hospitalization when administered early. So we know the EUA criteria is only the first 10 days of symptoms. The first EUA criteria listed very strict clinical guidelines, whether it was obesity or diabetes. Those EUA criteria have really iterated specifically for Regeneron and Lilly, actually for all 3, to now include clinician discretion. In other words, if you have a patient that tests positive for COVID and the EUA from the FDA does not differentiate between PCR or rapid, they test positive, they're in the first 10 days of symptomatology, there's now a new criteria that says, and I as a clinician am concerned that they will progress further and get severe COVID. So I think that's really a game changer for us clinicians, that now the FDA has opened. By the way, if you have a 38-year-old that maybe doesn't meet the obesity criteria, maybe doesn't have diabetes, thank God, but you're worried, then they actually qualify for these monoclonal antibodies. Once again, the 3 EUA approved. I tried to limit my slides. I typically give this talk over an hour. There's a little bit of intricacies down below. The federal government has purchased all the Lilly and Regeneron product, so there is no cost across this nation for these 2 products. The third, which is GlaxoSmithKline, is pure private sector, so hospitals and clinics can order it. But the first 2, Lilly and Regeneron, are paid for by the United States government. We have paused shipment of the BAM-EDI because of the emergence of variants. Suffice it to say that Regeneron is effective against Delta. That provides reassurance to me as a clinician. Likewise, behind the scenes, the FDA, CDC, and the pharmaceutical companies are on a regular basis testing these monoclonal antibodies against the emerging variants. So for this slide, the bottom line up front for clinicians is these are effective therapies. They need to be administered in the first 10 days of symptomatology. And if we go to the next slide, it's been really interesting to me, being involved almost a year now full time, how the EUAs have iterated. And this was breaking news from last Friday, that the FDA has now authorized the Regeneron, one of the 2 products that USG, the United States government, have purchased, for post-exposure prophylaxis. So in other words, and I didn't bring a whole lot of detailed slides, I can certainly send out information if folks are interested. You have a patient in a congregate setting, in a nursing home. They have been exposed, and the CDC has criteria for high-risk exposure. They now qualify in a prophylactic way for the Regeneron therapy. Once again, broadening these EUA criteria to get these effective therapies into patients, I think, is game-changing. And even more breaking news, literally as I was logging in to the webinar, I got an update from New England Journal that Regeneron just published the data that got this EUA approved by the FDA for post-exposure prophylaxis. So it's a lot to take in, it's a lot to keep track of, and I'm gonna add one more operational issue on the next slide. It's really easy for me, as somebody representing the Assistant Secretary of Preparedness and Response, to talk about getting these therapies. I'm sorry, next slide. It's easy for me to say this as somebody, and by the way, I'm a contractor for the federal government, so I don't speak on behalf of the federal government. Oh, I'm sorry. I shouldn't have said it twice. Could you back up one? It's easy for me to say, give these therapies in as many venues as possible, because now there's also a subcutaneous route of Regeneron available. We've seen fascinating models of administering monoclonal antibodies. They go anywhere from the hospital to the urgent care center, to the emergency department, to primary care clinics, to mobile assets. So these therapies, it's not like setting up an intensive care unit. We've seen very innovative models across the nation where people understand, if I can prevent more patients from progressing, I can then prevent more patients from needing hospitalization. It's good for that individual patient. It's also good for our very fragile and very tired and very burned out healthcare system that we don't have the emergency departments flooded again with more and more patients. It's really disconcerting across this nation, primarily because of vaccine hesitancy, that we are seeing hospitals that are at the breaking point again. So if we've got this tool in our tool belt, if we have effective therapies, of which these 3 monoclonal antibodies are, then we, once again, academia, the government, and the private sector need to figure out how to get these therapies into more and more patients. So that's a very high-level overview. I'm once again so appreciative of ACR inviting me to be a part of this, and I look forward to taking any questions.
Thank you, Dr. Anderson. So at this point, we will be shifting gears to basically have a Q&A session here. So Quaz and I have been manning the Q&A box. Quaz, do you want to start off with a couple questions here to get us rolling?
Okay, I got myself unmuted here. So Dr. Kim has done an outstanding job of going through some of these questions too, and has answered a bunch of them. I think we got, there's just a lot of great questions and really fantastic talks. I know I just learned a ton, and in fact, I'd kind of like to go back and look at this again on the recording. There's a lot of great information. So there was a lot of common themes with the questions, and one of the common themes is, should we be checking antibody levels in patients after they're vaccinated? And we know what the official recommendations are, is to not do that on a routine basis. But are there any situations where you think it would be appropriate? And if so, what tests do you order? And how do you interpret the results? And is there a cutoff that's meaningful to you?
So Kawase, you're starting off with a pretty spicy question.
Yeah.
This has been very controversial, largely because I actually still think that the results are inactionable, especially now. I think that with the Delta variant, the answers become much easier to answer because, really we should have universal masking again to, at least try to attenuate some of the R naught value, or the amount of people that can, you can transmit the virus to. And I say it's also inactionable because of the EUA indications, both, well, and this is going to be changing potentially very soon here, especially with vaccinations. People have gotten boosters within our cohort and within our patients. They have had to lie in order to get these boosters, right? And so, this opens up a little bit of a dangerous situation where patients do act on their own in the absence of information. This could be unintentionally self-defeating for those who remember a year and a half ago about hydroxychloroquine. This had led to some issues that several of us, including Jean and I, have been very vocal about a year ago. But the other issue too is going to be the type of test that is used. There is so much heterogeneity. You have the qualitative test, which just say yes or no, you have antibodies. You have the semi-qualitative or semi-quantitative, which says, okay, it's going to be absent, low, normal, whatever. And then there are going to be the fully quantitative ones, which are going to give you an actual level. The problem, again, is how do you interpret that, especially the ones that are quantitative. We still don't know what level means protection. And again, this theme comes up over and over again. I know this is super frustrating for patients because they want to know what their levels are and they want to know if they're protected. We're just not very close to that specific answer. So and again, you may have disagreements amongst providers about this. My own specific view is not to test still, because again, those results are inactionable. And if you get those results, they're hard to interpret overall. So until there is some sort of standardization of this, I just think it can get people in more trouble than is worth.
Al, also you talked about B-cell antibodies or the B-cell depleters and, the 6 months and the data you showed, basically the longer you wait, the better it gets, to summarize. Do you think there's any role of checking CD19 levels prior to immunizing? Is that something you would recommend?
Yeah. So before, I think intuitively the answer makes sense, but I think again this Thomas Derner data that came out in medRxiv is, showing that level that of 10 cells per microliter. Again, you just need this reemergence of blood peripheral B cells, and that seems to be a really good correlate of whether or not you're going to be generating antibody responses. So I think in this particular situation with the data that's there, I think there is probably justification to do so.
Can I add one thing on the sero status just briefly? It's Mike Anderson. We've been asked, or both the pharmaceutical companies and the federal COVID response have been asked, what are the roles of monoclonals inpatient? If I've got somebody that's sick enough to be admitted, wouldn't it be nice to give them a boost of antibodies? There's one report from the Regeneron Corporation that shows a decrease in mortality, all in mortality at 28 days. Interestingly, only in the patients that were seronegative, and the intensive care community is kind of scratching its head because testing seropositivity versus negativity is not really standard of care as you get admitted to ICU. So there's also antibody information that may be out there as far as sero status.
There's another question for you here, Dr. Anderson, and it's about pediatrics. So are any data regarding pediatric patients benefiting from the monoclonal antibodies?
No data, and I'm, as a pediatrician, a little ashamed to say not great uptake in the 12 to 17-year-olds, of which the EUA protects them. We have seen terrific engagement from the sickle cell advocacy community, trying to get more and more kids because of sickle cell and their basically asplenic status. I think going into this winter, as I sort of mentioned in my preamble, I hope there's better uptake, but there's certainly no data that I've seen published in kids 12 to 17, although it is EUA approved.
And Dr. Anderson, just so if I have a patient who has COVID and I find out about it, tonight, and I think that there's someone who's at high risk, is there a federal government website I go to, or is this something does it depend on your local, your location? How would I proceed?
It's a little bit of both. So there's combatcovid.hhs.gov, and there's a tracker there that is updated as much as we can given the complexity of the system. I also think it's probably good information for all clinicians in this country to know, does my local FQHC do this? Because we've seen federally qualified health centers. Does my academic medical center do it? We've seen leaders in this country. And we've also seen primary care practices have reached out, especially because there is now the approval of the subcutaneous administration. So I guess I'm answering both ways. There is a website, combatcovid.hhs.gov. I also think it's incumbent for clinicians to know, I spent 30 years in Northeast Ohio and Cleveland. I know both the clinic and UH and a lot of those satellites are prescribing. So I think you gotta sort of take the pulse of your local community.
Thank you. Quaz, do you have one ready to go?
Here's a question. It's probably for Jean here. And unfortunately, so many people are asking questions that keeps going. I keep losing my place here.
I'm sorry, I keep answering them. So yes, I will take a question so I can stop answering by typing.
Oh no, that's okay. So it was a question about patients. It's probably about vaccine hesitancy or any potential risks of vaccines, and it was about patients with kind of newly diagnosed autoimmune diseases with high levels of disease activity that might be concerned about getting a vaccine in terms of, is that going to risk kind of any worsening of their disease?
I think that's hard to say. I think overall, the ACR recommends that everyone get a COVID-19 vaccination. Then it becomes nuanced, and they answer the question in the Q&A about this, about which one is better. The ACR doesn't say which one is better, but I think, if you have the chance to get an mRNA vaccine, please get it. And there are, of course, questions that you should discuss with your rheumatologist about appropriate timing. If you've got a newly diagnosed disease and it's very active, probably you're on steroids like prednisone at some higher dose. If your rheumatologist feels that you will soon be able to wean down on that dose, and that's going to happen pretty soon, and I think it's reasonable in that case to wait until that point to get the vaccine so that you don't have the interference from the steroids tamping down the immune response in part. However, if your rheumatologist feels that they can't really forecast if you're going to be able to get down on your medication burden like pretty quickly, I think getting vaccinated is just the way to go. And then hopefully we'll get more information from these studies that are ongoing about getting booster vaccines. Because I think that's always a possibility. If we find that they're safe and effective, then that might change our recommendations. And it's not over with just the information we have now.
Yeah, got a follow-up question on that, but this is just slightly related, but this is kind of an interesting sort of fun question. Somebody asked, is there any association between the side effects that you get from the vaccine and the response to the vaccine? I remember back when we all got our first shots back in December and January, those of us that got a sore arm or just felt lousy and fatigued would console each other saying, well, at least you probably had a good response. But that was a very non-scientific thought process. Has there been any data that, or any association between people that have a lot of side effects or no side effects in their response to the vaccine?
We had a lot of discussion about this on Twitter amongst ourselves at the beginning, and I still haven't seen a study that exactly addresses that question. And I personally didn't really have a ton of side effects beyond just feeling like kind of prodromal fatigue. So hopefully I mounted a good response. I have no idea. But it's, interesting that I haven't yet seen a study that answers that question.
I had 6 hours of Rigers, and I was never more happy to have Rigers in my life. So I hope it was a great response.
This goes to Jean, and Jean, I don't know if you can answer this specifically because you didn't cover it in your talk here today, but is there any data on mortality rates for COVID-19 patients with rheumatic disease with your work with the GRA?
Yeah, so I've talked about this in prior studies, but you can look at it in different ways. So the GRA is a physician-entered voluntary registry, and we only have people with rheumatic disease who also had COVID-19. So we can't make comparators to the general population of COVID-19, and we can't make comparisons to people who had rheumatic disease but didn't have COVID-19. But in our second big publication about 2,500 cases, we looked at the outcome of death, and the factors that were associated with a higher risk of death were older age, comorbidities as in general population, and then more rheumatic disease specific things were being on prednisone doses that are higher than 10 milligrams per day, being on rituximab, and then having moderate or severe disease activity. And then we also saw that there was an interaction between being on steroids and having high disease activity. So that would address the question of death as a COVID-19 outcome if you were a patient with rheumatic disease that had a diagnosis of COVID-19. So then to answer the question a different way, what about risk of death or risk of hospitalization, ICU admission, if you're a patient with rheumatic disease compared to the general population? So you can't answer that with the GRA registry, but people have used different large data sources to answer the question. So the group out of Harvard has used various electronic medical record databases, like the Silva et al. Looked at Trinetics, which is like a combination of many institutions' EMR data, and they looked at a list of different outcomes, including hospitalization, severe hospitalization, and saw that people with rheumatic disease had a higher risk of this compared to their matched general comparators that are matched on like age, sex, and BMI. And then there's a Scandinavian registry study that looked at this, and the UK did an interesting registry with rare autoimmune diseases, and they looked at mortality rates, and that was also higher than the general UK population. And there have been others as well, but those are kind of the highlights of what we know thus far.
I've seen a few questions here about does anybody have any insight or inside information on when we could expect vaccines to be available for kids under the age of 12?
It's Mike. It's not really inside information, but I know CDC is working hard on it along with the drug manufacturers. I've been on a couple of calls with really concerned pediatric advocates. Schools back, masks have become political. The unvaccinated are the ones that are suffering from Delta. RSV has come back with a vengeance this year, and ICUs are full. It's just a really bad mix for kids, and it's my keen sense of the obvious. So I know that CDC and the manufacturers are feeling, of course, do it safely, but boy, I'm sure hoping that comes by fall. I don't have inside information, but I think I'm as anxious as every rheumatologist on this call.
Absolutely. And there's some questions here about boosters, and these are also questions we probably don't have an exact answer for. I mean, there's just a ton of interest in boosters, and some people are asking questions. Not only, when can we anticipate that happening, but is there a risk to giving the booster too soon after the initial vaccine? Who might get a booster? Anybody want to tackle that?
Kind of, again, another data-free zone. I mean, certainly from data from Dori Segev's group, data from France and also Israel with solid organ transplant people, it appears to be safe, which is really probably the most important thing. And then there's variable improvement in responses. It seems that those people who've had poor responses did better than those that had no responses. In the rheumatic disease population, I do think that eventually boosters will become part of the armamentarium for the providers, and in order to be able to mitigate some of the risks from immunosuppression. Who is it going to be given to? Is it only going to be those with poor initial responses, or those just generally on immunosuppression that have mounted some responses before? A lot of this really, I think, depends on the impact of specific immunosuppressives on cross-variant neutralization. In other words, let's say a certain drug may attenuate the ability for antibodies to diversify normally, and as a result, you can't protect yourself against Delta even though your antibody titers are normal. Right. So again, there's a lot of nuances. We are starting to look at Delta variant in our study this month with Mike Diamond. And so hopefully we'll be able to get a preliminary look at that later this month or early next month to be able to get an idea of what variant protection looks like in the immunosuppressed.
Real briefly, Al, there's a question here and I'm paraphrasing a little bit, but is there a gold standard antibody test that you're using or that is accepted, or does anybody know at this point?
I certainly don't know that answer. Everyone likes their own product. And for example, in our study, we have a home brew. In other words, one generated within the lab. We're not even testing, we're using commercial. And I know with like the Moderna clinical trials, they also had another homebrew assay versus I think Pfizer may have used Roche. I can't remember off the top of my head. So, even in the clinical trials, right, there's all this variance. And I think that gives you an idea of how, little we know about, cross-test performance equivalency. This doesn't really exist. And so again, this highlights some of the issues in terms of the standardization of these assays.
All right. Klaus, do we have time for one more? Do you have a quick question ready to go?
Well, another question that came up in regards to boosters is, does anybody have thoughts on, will it be better to get a booster with the same vaccine that you got initially, or should you switch it up? And I know there was some I don't know if it was some data reports in the transplant literature kind of looking at this early on in terms of switching. What are your thoughts on that?
Yeah, still kind of a largely data-free zone. The answers will come. I'm not going to provide details, but I know there are clinical trials in a wide variety of the immunosuppressed rheumatic disease patients, transplant patients, cancer patients that are going to look at this very specifically with boosters. So there are, again, that doesn't help the people that are potentially maybe getting boosted in the fall. All right. And I think we'll get probably some real-time data before the formal results of these clinical trials wrap up and present. But nevertheless, I think, again, it's hard to say. One could make the argument you just need re-exposure to antigen and get, the responses back up and going again. There are arguments that, maybe you need to stick with the same line or same platform. The reason why there's conflicting arguments is because we don't know the answer. Oh, yes. And then Jean Liew just mentioned that the GRA is looking at this. There's a study ongoing through the Rheum COVID website.
Awesome. Thank you. Well, we are out of time. I want to thank everybody for their participation. I want to thank the panelists for taking the time to prepare their talks. It was a wonderful, wonderful discussion that we probably could go on for another couple hours, but unfortunately we are out of time for now. So I want to thank everybody for their time and attention here tonight. I want to thank you all for tuning in. I want to bring your attention to the ACR's website. There's a plethora of information on COVID-19 available. And I even printed signs from my office today from this website. So there's plenty of information you can look at, both scientific and clinical, for your clinics. I also want to bring your attention to the fact that there is a new version of the manuscript out for the clinical vaccine clinical guidance that is available here in the very near future on the website as well. It'll be an ANR as well. So with that, I will conclude our town hall. I want to thank you all for your time and attention and wish you all a good night.